Welcome back to the Energized podcast, Dr. Gersh. It is such a pleasure for you to be here today. And thank you for coming on your beautiful Saturday morning.
Well, I'm thrilled to, and this is actually one of the highlights of my day. So no problem whatsoever.
Well, I am so grateful to have you. And what we are one of my go-to experts when it comes to, helping women navigate perimenopause and menopause by, not only with ease and grace, but also by helping to ensure that they have an amazing health span. As you and I both know, this is half of our life. And probably the most important and a part, we have families at this point. We're in communities. We're in our careers. I find this to be one of the most important aspects of our life. And yet, I feel like so many women are uneducated about how to tend to their body, and most importantly, how to tend to their mental health as they navigate these big hormone shifts. So I would love to dive into kind of that question around perimenopause. And just the first question I want to ask you is, are you a fan, or is it something that you recommend around perimenopause to start women on bioidentical hormones or some type of hormone support if indeed it's called for?
Well, it is now, but it wasn't always, because
No.
it is not the conventional medical approach to start hormones at all, especially when a woman is still having periods. So there's an arbitrary definition of menopause, as many have heard. It's 12 consecutive months without any bleeding. And I can't even say a period, because who knows what that bleeding is. It's if you go 3-4 months and you don't bleed, you probably are having dysfunctional uterine bleeding, which is not related to ovulation. It's just some estrogen that made the uterine lining get too big, and then it literally started falling out, and that's bleeding. So that's an arbitrary definition, and it's not based on health. It's just based on, well, probably by that point, a woman is not going to be fertile, so she doesn't have to worry about birth control. It's all based on other kinds of issues, certainly not mental health. But once you recognize that it's a transitional type of a situation, we're dealing with ovarian aging or ovarian senescence. It's just the decline of ovarian health, loss of eggs, loss of healthy, optimal functioning of the ovaries and the eggs. And therefore, we have changes in hormonal production, which have huge effects, huge ramifications all over the body. And this process is occurring, of course, throughout the woman's life. That's why it parallels fertility. That's why fertility is much higher in the early 20s than even into the 30s and late 30s. It's really declining. And then in the 40s, it plummets, but not all the way. But usually once you get over 45, it's generally not present, even for women who are having regular cycles. So there's a parallel there, and hormones are changing, and it's affecting the body. Now that we understand that this is a process, it's not like crossing the finish line. All of this needs to be considered in terms of our therapeutic approach. So during the perimenopause, when hormones are declining and fluctuating and creating a lot of havoc, loss of bone, change in mood and cognition and sleep quality, loss of collagen, and a lot of other things in the skin.
Metabolic health.
Oh my gosh, insulin resistance, gut health, like every organ system is impacted. So now I very routinely give women what I call, and I have to create my own vocabulary because it doesn't even exist. During the perimenopause, I just call it very simply hormone supplementation.
I
And
love
during
it.
menopause, when there's no longer ovarian function in terms of producing estradiol, the estrogen that the ovaries produce, and the progesterone, then I call it hormone replacement therapy, which, by the way, that expression has now been shunned by the conventional medical world, and they replaced it with menopausal hormone therapy. And there's nothing really wrong with that, but it's not really giving what I am trying to give, which is truly hormone replacement. I'm not just trying to give a little bit on the top just to kind of ameliorate some of the symptoms. I'm really trying to go for what you said, health span. We want to have a healthy longevity, not just be alive. So I'm going to give hormones to try to optimize health for every organ system, not just suppress one or two symptoms.
I really appreciate you saying that, because that is exactly the trend that I've seen across the board in conventional medicine is they'll give women a little bit, and then they kind of have a cap. And they're like, if your even if your symptoms aren't gone, I won't go beyond that cap, because that could drive breast cancer, or that could drive whatever scary thing that they're concerned with. But we would never do that to women with a thyroid hormone. Like, until we can get your levels back to where they need to be, optimal, like a TSH of a 1.5 to 2, we will keep raising up that hormone, dosage until we get there. But that's not the case for an estradiol patch or some type of bioidentical hormone. And so I love that your approach is like, no, I'm trying to get women back to where it's going to have an impact on their health span and actually carry them through the next decades of their life to improve their bone health, their cardiovascular health, their cognitive health, which is what we all deserve.
And your analogy with thyroid is really perfect, because that's another hormone. It's part
Right.
of the endocrine system. And no one would ever say, well, your thyroid is low, it's suboptimal, but let's wait until it's 0 before we even consider giving you any thyroid hormone. So unless you have no thyroid gland, which does happen when people have their thyroid gland removed, say for thyroid cancer,
Mm-hmm.
then it's truly thyroid replacement. But for the vast majority of women make up the bulk, although not all the people on thyroid hormone as a need for health. We call it thyroid supplementation. We're not replacing all the thyroid hormone, because you still have some, you're just augmenting it. And that's the perimenopause. You do have hormones, but it's not optimal. And when we're doing integrative and functional medicine, yeah, I know it's hard and impossible actually to achieve, but we're striving for optimal, not just passable.
I agree. I want to talk. I know I would love to gear into menopause as well. But as you had mentioned, supplementation, hormone supplementation, I love that during perimenopause, because what a lot of women don't realize is that there is a decline happening, and probably sooner than they think is happening, and that is driving a lot of those symptoms that they're experiencing. And a cluster of symptoms that you and I talked about before we got on was the cluster of symptoms around mental health. We know that women are, we see a greater amount of mood disorders in perimenopause, more than childbearing years, and even postmenopause. Like in this particular 10-year transition, give or take, that's where things can get pretty dicey. And women experience more depression, more anxiety, more rage, more irritability. That's one of the most common symptoms, is women are just over it, and a lot of us are like, well, maybe this is just shedding of my accommodation. Like, I'm just not accommodating to people anymore. Like, I'm really in my true essence. But no, we know that these hormones, as they decline, are having a profound impact on neurotransmitters. And if neurotransmitters were potentially already low, we can see an exacerbation of those symptoms. And so I'd love to know, what have you seen in your practice as women are navigating this transition? I know I just had an episode go out talking about my own lived experience, and I feel like my body's possessed about 3 to 5 days leading up to my period. And I have intense rage and intense anger. And life feels insurmountable to me. Like 2 days ago, I could handle life. I'm the CEO of all parts of my life. And then 2 days later, all of a sudden, it's like I have this deep sense of dread that I feel like just is a big tidal wave that comes over me. And even on 200 milligrams of prometrium, I can't seem to get it under control.
Well, you first of all said something really key, and that is that estradiol is really key to neurotransmitter production, function, everything, the receptors working. So if we look at some of the neurotransmitters that are affected, we're talking about dopamine, we're talking about serotonin, from which comes melatonin, we're talking about oxytocin, the bonding love, what you can call either a hormone neurotransmitter, it's kind of both, and acetylcholine, which is about creating memories. And more than that, in the brain, it's about memory creation. but in the peripheral system with the autonomic nervous system, it is the neurotransmitter of the parasympathetic nervous system, or what we call the vagus nerve. And the vagus nerve, in order to keep everything sort of in just a calm, normal state, it needs acetylcholine. That's its neurotransmitter. And that's why there's so much push for what we call vagus nerve stimulation. And a lot of the mind-body medicine is all about increasing vagal tone. That's like the expression we use. And that creates a host of really beneficial effects throughout the body, but it really keeps you calm and happy, not in road rage with or without the road. So all of these are really critical neurotransmitters that are impacted in every way, in terms of how they're produced, how they're transmitted, how their receptor is working. And just like those supposed, we're not even sure this is how they work, drugs that are called SSRIs, serotonin
reuptake inhibitors.
Inhibitors. Well, it turns out that estradiol is exactly that. It is
its own natural, yes.
It is. It actually keeps serotonin longer in the synapse by reducing reuptake. It actually works, among other ways, that it works to improve the health of the so-called serotonin neurons, the ones that produce serotonin. So when you're having fluctuations and reduced production of estradiol, you're going to impact on every aspect of mental health. Now, you mentioned during the menstrual cycle, during the luteal phase.
Yeah, the late luteal phase is
right,
where I'm losing my stuff.
So this is important to understand the incredible dynamics of the hormones and their effects in the brain during the menstrual cycle. So estradiol starts out really low during the part where you're bleeding, the shedding phase. Now, it needs to be low at that time because you're shedding the lining. You're not trying to grow the lining.
Right, because that's what estrogen does. It grows the lining. We want to get rid of the lining. Yes.
At that moment. Now, part of the amazing aspects of estradiol is its pro-growth or proliferation. It creates and stimulates the growth factors. Now, in the brain, it increases like brain-derived neurotrophic factor, which improves cognition and mood. So it does all that. In the uterus, the growth factors create growth of the uterine lining called the endometrium. So at the time when you're having your period, estradiol is at its lowest, not just in the uterine lining, but also in the brain. Yes.
I can't tell you how excited I am about day 5, day 6, where that little hit, that estradiol is on the come up. I'm just like, oh, come on, day 5, you know?
So what is supposed to happen is during that time that you would have enough like resilience, but not everybody has that. Now, and then the other thing that I always recommend is using nature's gift to women and men too, but we'll focus on women. And that is the wide array of phytoestrogens that come from foods that can have dramatic effects. So don't underestimate medicine from food. Like, we call it food is medicine. Yeah, these absolutely. Little phytoestrogens that are, and we can talk more about that, but that's one of the therapeutics that I always employ. Now, and getting back to what's going on in the menstrual cycle, as you start proceeding through the follicular or proliferative, now follicular is how you talk about the first half of the menstrual cycle when you're referring to the ovary, and proliferative is what you're talking about when you're talking about the uterine lining. It's funny how we have these like dual words. So you're proliferating the uterine lining, and in the ovary, the follicles are developing. So that's why we have follicular and proliferative phase. And the estradiol level is, as you said, it's rising. Now, when you get to around, if you have a 28-day cycle, around day 12, you get this giant spike of estradiol. Now, when you have that giant spike, that is the most anti-inflammatory. So estradiol modulates every aspect of the immune system, every aspect. Every immune cell in the body has estrogen receptors. And the cells that are called the innate immune system, these are the macrophages, the neutrophils, the mast cells, the monocytes, that they are like the first attack part of the immune system, if you have injury or pathogens trying to get in the body, those are actually down regulated, like they're sort of suppressed a bit when you have that really high estradiol, which actually is, of course, has a major purpose. It's so that you don't have your immune system destroy the sperm, which are really foreign entities, right? Just like a pathogen, it has different proteins than our own cells. So the immune system is quieted right around the time that you would have sex and the sperm would come in, so you don't kill it. And then what happens is after that, you have this giant luteinizing hormone, LH spike, and that triggers ovulation. Now, it turns out that in the brain and elsewhere in the body, but we'll focus on the brain, there's this other amazing system called the endocannabinoid system. And it's a lipid signaling system made from fatty acids derived from omega-6. And there's a few different ones, and then there's like relatives, and the plants, hemp and marijuana, cannabis, they have their own little magical plant ingredients that actually, like cannabis, that can bind to the receptors of our own innate system or endogenous system. So we're not going to talk about cannabis here, but we're just going to talk about, but now, you know, that's another whole topic we could talk about another day. But just so you know, that's where the name endocannabinoid system came from. It was like reverse engineering. First, they discovered that cannabis affected the body, and then it bound to receptors, but nobody knew how this system worked. Then they discovered that specifically the receptors, and that we had our own signaling agents called, and then they named them endocannabinoids after cannabis. So endo means within us, endo, and cannabinoid is from cannabis. So that's like the ultimate reverse engineering. So our own system, the endocannabinoid system, has in the brain tremendous anxiolytic effects. That means lowering anxiety. So it turns out that one of the endocannabinoids called anandamide, it has this incredible, as do the others, but that one we'll talk about specifically, has this incredible relationship with estrogen and progesterone. So estradiol, as it rises, increases the production of anandamide, and anandamide calms everybody down, calms everyone down. So a lot of the activity that estradiol has as a reducing agent for anxiety is probably through its action through the endocannabinoid system, like as a second messenger from the estradiol, kind of like a relay, you know, like the estradiol increases the anandamide, and that is the calming effect. So that is increased when you have that big spike of estradiol. But then after you have the spike, and there's a feedback system, so the anandamide that gets higher, it then feeds back on LH, luteinizing hormone, which then drops because it spikes and it drops, and then the estradiol drops. So there's actually a big drop, and for some women, it actually dips pretty low right after ovulation.
Right after ovulation, yeah.
Yes, it actually, and that's when some women will have spotting, like they call it mid-cycle spotting, and even a little cramping because of the estradiol dropping so much. And for some, that can be like a little startling into their emotions because the anandamide suddenly dropped, the estradiol dropped after just being so high. But then,
and I've heard that before, that right after ovulation, some women feel a little heightened sense of anxiety, or they just feel a mood shift. That they can, like some women are like, it happens twice in my cycle.
Yeah,
it happens
exactly.
here and here, you know. And so thanks for acknowledging kind of the process of what's happening.
And also when you get that big spike of estradiol, it upregulates the receptors. So the receptors work better for testosterone, which also makes people feel good. Yes. Testosterone is also has a lot of effects in the brain. It's also neuroprotective, and it increases the receptors for progesterone, which is very anti-inflammatory. It also neuroprotective and also calming. But what happens is then as you start producing all that progesterone in the second part, the luteal phase of the menstrual cycle, or the secretory, when you're talking about the uterine lining. So it's luteal for the ovary, secretory for the uterine lining. Then progesterone goes up high. Progesterone, in turn, down-regulates the endocannabinoid system big time, drops it very low, and it stays low if you're pregnant throughout the whole pregnancy, and it rises right at the time you go into labor. It's like a really fascinating thing. And then it lowers the receptor function of the estrogen too. So now you have this yin yang kind of issue. You're sort of on thin ice. You have progesterone, which is neuroprotective and calming and can increase GABA and sleep and relaxation in some ways, but you're also decreasing your anandamide, the feel-good endocannabinoid. You're decreasing the receptor function of the estradiol. So now you have this sort of crazy balance, which for some women, it isn't working. It isn't working for them, and they're having emotional swings. So
even earlier, like even we're talking about mid-luteal phase.
Oh, yes, because it's happening as soon as the progesterone is produced, because you get the drop as soon as you have progesterone. As soon as you have progesterone, you're dropping your endocannabinoid production, because progesterone suppresses the endocannabinoids, whereas estradiol increases them. This is like this huge balance. It's always going on in the body between different receptors and other systems and the interactions between them. So now you have your progesterone that's reducing your endocannabinoids, those feel good. You're reducing your estradiol, your estradiol receptors. And by reducing your estradiol, you're going at receptor function, you're going to impact on a number of neurotransmitters and so on, and you're going to impact mood. And it's really variable from woman to woman. And for some women, this can trigger a great deal of emotional imbalance and stress. So what I recommend, and there's no clear-cut, easy answer for this, is number one, definitely eat a lot of phytoestrogens. And those are like lignans. Those come from things like flaxseed. A lot of women know you're supposed to eat a lot of flaxseed, but all seeds and nuts have lignans. And then soy. Now, poor soy has been maligned a lot too, but organic, whole, unprocessed would be like the bean, the edamame, tofu, miso, tempeh. But of course, if you don't have an allergic reaction or other problems, but it also has been shown, it has the isoflavones. And then fruits like red grapes have resveratrol, and apples, onions, garlic, they have quercetin, which also reduce inflammation, and pomegranates, ellagic acid. These are all phytoestrogen containing plants that can really help a great deal with mood. And then also the whole also the whole grains. So they also have a lot of the lignans. And so these can really help with mood. So what else can we do? I love to do menstrual mapping testing, because often what we find, especially in women as they're going into their late 30s and 40s, but sometimes earlier, what do we find? We find that they're actually ovulating and they're having regular cycles, but they're not producing enough. Enough what? But it could be estradiol, or it could be progesterone, or it could be both. So instead of just saying, I'll just give you progesterone, sometimes that's not the answer. A lot of times the answer is give estradiol, because you're suppressing it too much and you're not making enough. And so you really give a little bit of estradiol back. You don't give any progesterone, just estradiol, and you can change the whole paradigm. In fact, it affects women so well, they're now showing that you can give it back to women who have bipolar 2 disease, and it can help. You can give it to women who have postpartum depression, and it can help. So they're finding that giving estradiol, not progesterone, can make a huge difference. But for some people, it is the progesterone. So you can't make a great generalization about this, because there's this incredible balance between these hormones that in some people, it can be dysregulated. And for some women where the progesterone isn't enough, what lowers the natural production of progesterone in the luteal phase? Inflammation. So if you have inflammation in your ovary from any source, like endocrine disruptors, lack of sleep, high stress, sedentary lifestyle, poor nutrient intake, anything and everything, chronic infections. So anything that can cause inflammation in the ovary can reduce the production of progesterone. So I just take a very personalized approach to this with every patient. I want to see what's going on during her luteal phase instead of just saying, we'll just try this or we'll just try this, that type of thing. So it really can make a huge difference. And then women, like you mentioned, who have this kind of issue during even their young years, like in their 20s and 30s, when they hit perimenopause, their chance of having exacerbated mental health problems, anxiety, depression, mood swings goes up 400%. In a woman who never had any previous issues, it doubles. So what are the statistics? Women in their 40s and 50s, almost a quarter of them are on antidepressants. What is that saying about our health, our world, and our medical approach to perimenopause and early menopause, to think that almost a quarter of all women are being put on antidepressants, which they use for everything, including PMS, including, you name it. They're, what hot flashes, they're giving antidepressants. So you know how we are. We want to give what you're deficient in. If you are deficient in B12 and you're having depressive symptoms or B6, which is also a very important vitamin for mood, we don't give an antidepressant, we give the vitamin you're deficient in, right? We want to treat the real cause. And the real cause is not that you have a deficiency of this drug. Maybe you do have a deficiency of serotonin, but there are better ways to get your serotonin up than to give this pharmaceutical. And also the pharmaceutical is not going to help your bones. In fact, SSRIs increase osteoporosis, the exact opposite of what we want.
And I knew that. Yeah. I want to just go back a little bit on the menstrual mapping. Dr. Gersh, how are you assessing? Is it just multiple blood tests over that luteal phase? How are you getting clarity on, because obviously both estradiol and progesterone are at play in the luteal phase. And so and I'm not sure if you're looking at estradiol also in the follicular phase, or if you're just looking at it when it's on that rise after post ovulation. But I was curious, is there because I know a lot of women go in to get their hormones tested, and a lot of doctors have no idea what they're doing. And they kind of miss the boat on how to really determine what's going on. But then also, we're also just guessing most of the time.
Well, yeah. And so I love data. So if I can get it and it's not going to be invasive or prohibitively expensive, and it really isn't. So that would be a way to do it, to get lots and lots of blood tests, but that would not be terribly popular. So
No.
this is done through dried urine. So it's
Okay, yes.
multiple urine specimens throughout the entire cycle, the follicular phase and the luteal phase.
Got it.
And then by looking at the urine metabolites, you can actually then create an incredible graph. And there are a couple of companies that do this. And you actually get a graph of the actual menstrual cycle of your estradiol. You can actually see exactly what's happening, the spike. And then the progesterone, and also looks at luteinizing hormone. Some labs do other things as well. So this gives you an amazing pictorial, exactly what's happening that cycle with these hormones. And it's really fantastic. So you have what's the ideal? Because you always want to compare against this ideal cycle. And there is variation, like everything in life. There's a reference range. So there's a range of normal, but we want to go to what's the ideal. And often the ideal and then the reality that I see in the test result, they're light years apart. Like, here's where the estradiol level should be, and this is what it is on this person's graph. And it's like everything is miniaturized. So you have a little spike. Instead of a big spike, you have a little spike, and you have a little rise of progesterone instead of this big, nice mound. And no wonder that you say, no wonder this person doesn't feel right. And then when you don't have the proper hormonal balance, you do get what I call road rage without the road, and it's really horrible, this irritability status where women feel so horrible. They're like, wanting to like eat their family alive. It's like
Yeah, yeah,
terrible.
that's what it feels like.
And they're like, the monster woman has arrived. So we don't want that. Nobody wants that. And they can't control it. And they don't want to go on a lot of pharmaceuticals because, first of all, they know that that's not really addressing why this is happening, but that is the standard approach. And that is not what we want for our female population.
It makes so much sense. And I'm curious too, because I know that in perimenopause, things can get I mean, obviously, we're talking about a decline. The hormones are declining. And I know that it's variable for every single woman. And I know that things are kind of, it seems to me that lifestyle is kind of speeding that up for some women who've dealt with stress or have a lot of adverse childhood events, that it seems to have been sped up. Maybe women are experiencing some of these more intense symptoms in their late 30s versus maybe 44. And so when you're looking at this, particularly for women in perimenopause, and I'm sure that there's still kind of optimals or ideals, but do you find that to be a little bit more challenging? Since I know that estradiol, I know that estradiol is kind of like, I feel like she can be on a roller coaster ride a little bit in this phase. Does it get a little bit more challenging for doctors to look at some of this? Because it can be a lot less consistent versus, the 30 years of, for some women having a more consistent cycle.
Well, for me, the most challenging group is the perimenopausal group.
Yeah,
Absolutely. Menopause has its own challenges, but
for sure.
it's easy because I know that the hormone level is for estradiol and progesterone is 0. Okay. So I'm
Right. It's
starting
just
from,
going to be where it's going to be.
like, it's right. It's like a clean slate. Whatever I give, that's what they get. Okay. Now, perimenopause is a whole different story here, because when I give hormone supplementation, it's not like giving a birth control pill at all. I'm not suppressing their ovarian function, like basically taking their ovaries offline and taking them out of the picture. They're not
Which,
doing anything.
by the way, is what most doctors are trying to do because they have no idea. I can't tell you how many women come to me and they're just like, I was just put on birth control because they were like, we don't know what to do with you. We don't know. That's how we're going to shut down these symptoms. And it just breaks my heart. It's such a disservice.
Well, it's an easy out for the
solution. Yes.
doctor.
Yeah.
But once you accept and really understand what birth control pills are, they are officially, and you can go to toxicology.gov, which is part of the NIH website. What does it say? They're endocrine disruptors. Every single element of a birth control pill, the ethinyl estradiol and the progestin, which is a made-up word for mimic but not real progesterone, they're all endocrine disruptors. In fact, their original point, was to disrupt your ovarian function so you couldn't become
pregnant. Yeah.
Exactly. And when you have ovarian challenges, we'll say the hormones are not being produced in a way that's creating the exact desired effect, then the easy solution is just get rid of them. Just stop having them work and then give something in exchange that will sometimes help symptoms. I can never deny that there can be some symptom improvement.
Yeah. And I can't deny that either.
But you're not giving you're not restoring anything. You're not like fixing the periods. You're getting rid of the periods. You may have bleeding, but it's real blood, but it's not because you ovulated. It's all smoke and mirrors.
Yeah.
And birth control pills do increase the risk of cervical cancer significantly. They increase the risk of breast cancer. They increase the risk of blood clots and hypertension. That's because they are pro-inflammatory. Part of the inflammatory response is increasing blood clotting and increasing constriction of your artery. It's all life-saving types of maneuvers of the body if you're either traumatized or you're infected with a pathogen, but you don't want this happening in your day-to-day life when nothing else is instituting the need for such events, like creating a pro-inflammatory state. That's why you'd never give birth control pills to someone who had blood clots or uncontrolled high blood pressure or had a heart attack, because they're not health pills. So that is not my first choice. The only time I would ever use those hormones would be as a pharmaceutical to deal with, say, acute hemorrhaging or some sort of thing. Then I'm using it a short-term pharmaceutical, but it's not hormone replacement, and it's not managing your hormones in a way that would be ideal, not even close. So it's a challenge with perimenopausal women, because when I give hormones, I am not putting their ovaries out of
A
order.
commission. And I'm
That's
curious,
right.
yeah, real quick on a little side note on, let's say a woman is put on 44, 45 on birth control because she's having pretty intense symptoms, maybe symptoms around like heavy bleeding.
Mhm.
And and then 52 comes along and she's still on them because no one told her otherwise. What kind of detriment has that impacted on her life and her health span if she'd been on those birth control pills to manage symptoms for those 7 years, when what could have been happening is, bringing her back to a place of optimal balance? I'm just curious, like, how much does that set us back? Do we understand that?
Actually, that's a fabulous question. And the answer is no, because no one's collecting the data. The only real data we have is, and this is now published and it's very limited, if you start birth control pills on a teen. This is like rampant now, very,
Yeah.
very young teens. In fact, it's considered totally medically acceptable to start birth control pills on any girl by 1 year past her first period, and to then be on them indefinitely.
Yeah.
So, I mean, we can give them now to 11, 12-year-olds. It's like unbelievable. And then they're just on them. But if you start them before the age of 20, so say in the teens, it increases lifetime risk of heart attacks and strokes. Now, what I can say in my own, and that's the only real published data, because we have very limited data. We do know if you are on birth control pills and you're young during the bone growing years, you will have a suboptimal skeleton.
Right,
You will
because it
not,
actually stunts that growth. I think we
it
peak
will.
around 26 or so, 27, and we don't have the foundation built. I also know it has a profound impact on brain development.
Oh, absolutely. And vaginal development and bladder development. So there's some data that if you start birth control pills and you're on them quite a while, nobody defines that, and you're young, you're more likely to have painful sex, to have vaginal discomfort, to have overactive bladder and frequent urination. So you have small bladder capacity. It affects the stretchiness of the bladder, so it doesn't take so much urine to make that sensation you got to go. So they do what I call bathroom mapping. Everywhere they look, where's the bathroom here, because I got to go. They can't walk past the bathroom. They got to go in every time, and that happens when you start birth control pills young. So we have more data on sexuality. It can increase sex hormone binding globulin, and that's a very important protein made by the liver, but you're not supposed to have it permanently high, and it can make it so it doesn't even come down. And so it binds up your testosterone so that you never have actual enough free or unbound testosterone to work and create the job that testosterone is supposed to do. So you may have lowered sex drive and sexual response forever if you start them, you're on them. But we don't have, isn't like fascinating, because it's such a great question. What if you're on them in your mid 40s into your, even up to age 55 is considered acceptable.
Yeah.
For those years, what does it mean for the rest of a woman's life, for her bone, for her brain, for her cardiovascular system, urological system, and so on? There's no data. Nobody wants it. But what I can tell you is what I observe. So in terms of what happens is estrogen that's in a birth control pill, it works on predominantly the alpha receptor, which is very important. Estrogen is a family. That's important to know as just a base for everyone. Maybe they didn't know this. Estrogen is not a hormone. It's a family of hormones. And in the human female adult, there's 3 types, and they each have a letter E and a number 1, 2, 3. And the one that the ovaries make is E2, or estradiol. Now, the estrogen that is predominantly coming from a birth control pill in the bloodstream is a different estrogen, estrone. Now, some of that will turn into estradiol too. It's not exclusively estrone, but it's heavily estrone. And there are different estrogen receptors, and the alpha receptor is the one that estrone predominantly binds to. estradiol binds to all the receptors in a beautiful, balanced way. So with receptors, we know this, and there's plenty of data on this. It's kind of like everything in life, use it or lose it.
Right.
So if you don't activate a receptor for a length of time, it becomes the equivalent of like rusty, okay? There's no real word for it. It just becomes less functional. And so this is a problem. Now, does it come back to life if you start putting the proper estrogen into that receptor? Somewhat. We don't really have great data. We know that it can come back to life somewhat over time, but it may never be as good. It, like it just is what it is. Like if you're put in bed for a long time, even not that long, what happens to your muscles? We know that you
The
can be put in a
atrophy,
leg
yeah.
cast and you take off the cast in 1 month and your thigh is half the size,
Yeah.
because you weren't using it. It's amazing that use it or lose it kind of
And that
thing.
was 1 month. We're talking 7 years here, or
Yeah.
however, this isn't months
But
that
what
women are being put on these.
they tend to be the hardest to actually get right when you give them hormones. I'm being totally honest, because the receptors are not receiving properly, and you really have to be patient. They can have irregular bleeding more often. They don't respond as well. They sometimes have like overshoot in terms of symptom response, because when you give estradiol, it works on all the receptors, and if you want to give a high enough amount to help stimulate the beta receptor, then you're giving more to the alpha receptor, and the alpha receptor, for example, is on the breast. So if you're trying to give enough to get the beta receptor going, which by the way is the dominant one in the cerebral
brain,
cortex, right, for mood,
for cognitive function. I mean, let's be
cognitive
honest,
function.
twice as
Yeah,
many women than men have dementia. Like
more,
this is,
yeah.
or
And
more,
so
yeah.
you're trying to get that beta receptor activated, and it's also the beta receptor is the dominant one in the GI tract. I mean, it's just really critically important, and it's been sort of not getting enough stimulation all the time. That on the birth control pills have gotten some, but not enough. So you're trying to push the dose to try to get those receptors back online, but simultaneously you're upregulating the receptors for the alpha receptor in the breast, and they get a lot of breast tenderness. And this is really a challenge. So we have to, everyone will get where they need to be, but it can take a while. So women who've been on birth control pills a long time, and then they hit menopause and suddenly they go off of them and now they want to go on hormones, it is more challenging.
Yeah,
but
and I've heard that a lot.
it is,
That is not a
and
fun ride.
that's not being written about.
No.
And
I've
what
heard
I'm
from so
finding,
many women in their own anecdotal experience of just like, this is just awful. And, and not understanding why. Again, there was no explanation as to what was happening. It's just like, man, this isn't working. Like, I feel worse because, of the impact that the birth control had for all those years.
and I'm thinking this through more and more now, because normally I am very against giving biased. So you may know biased. Biased is a blend of estriol, which is E3, the
Yes.
dominant estrogen of pregnancy made by the placenta. And there's always a little bit because it's also a derivative of estradiol, but it's very small quantity.
It's very small. Yeah.
Very small. But there's been this like trend of sorts in the functional medicine crowd to give a lot of this biased, where you give predominantly estriol and a little bit of estradiol, with the idea being that you're going to help with breast cancer prevention, because the alpha receptor is the dominant one there. But the problem is you need to have this balance. That's not natural. That's not physiologic.
I've been hearing the same thing, that it's a no-go.
It's not, but there may be a place for additional estriol as a transitional thing in women who've been on birth control pills a long time, because it's the beta receptor that wasn't getting the action to the same degree. So that may be a unique situation. That's not hormone replacement in the usual sense. It's almost like therapeutic repair of your beta receptor that you're trying to get more activated, that giving a little extra estriol, maybe for 6 months or something like that. Maybe, you know, this is something that we should think
Like a
about.
kickstart in a
A
way.
kickstart to exactly. And this is another issue for women who have been put on birth control pills. I'm seeing this all the time now. They're put on birth control pills when they're 13, and then when they're 32, can you believe this? Now
No,
they're
they're
going off
finally getting off.
and they want to have a baby.
Yeah, and
Okay,
they're told that maybe like within 3 months they could do that,
I
and
know.
maybe and that's it's mind
Some
blowing. I
of them
mean,
have been on birth control pills continuously for 20
20 years.
years, and now they go off of them and they explode with what? Testosterone. Like, what the heck? They're exploding with testosterone because nothing is working properly. The estrogen receptors in the brain aren't working right. So they're putting out all this excessive LH, luteinizing hormone, to try to trigger more estrogen production in the ovaries, which have been kind of on long-term sabbatical.
Like the
And
whole time
so,
sabbatical. Let's
yeah,
the
oh my
whole
God.
time.
And then so the ovaries, which is a whole different skill set, because the LH triggers testosterone, which is the precursor to estradiol. All estradiol is derived from testosterone.
Yes.
So you get this explosion of testosterone, but the enzyme aromatase in the ovary hasn't been used now for 20 years. So once again, use it or lose it. That enzyme doesn't just immediately come
Just
back
come
to life.
back.
The
No.
whole system is working right. Like you suppress everything for 20 years and then you think it's all going to be perfectly resurrected. It's not happening. I can tell you, it's just not happening. And so they don't convert the testosterone properly into the estradiol. The brain says, I want more estradiol, puts out more LH, more testosterone. So they all become like PCOS.
Yes.
They're all they're all getting acne, irregular cycles. And it's like, oh, the pills suppressed my PCOS symptoms. No, it created your PCOS.
Yeah, I always
The
think of a
function,
post-birth control syndrome,
yeah,
PCOS,
it
is
is,
like
and it's
this.
not talked about, you know, and like there's no research on it either. I mean, but I see this all the time, and it's like, there's like, where's the data on giving birth control pills starting at age 13, 14 for 20 consecutive years? Oh, there is none. There is no data. And what is that doing long term, like you mentioned, to the brain? We know that it's affecting the things that we've studied, like the cardiovascular and the bone. Why would we not think it's affecting the brain? What I worry about is they're going to get dementia
Yeah,
earlier,
no,
or
earlier.
higher
Well,
incidence.
aren't we already seeing that? Aren't
Well,
we
you
starting
know
to
what?
see?
But it's hard that this is the problem with so many things in medicine. The timeline from the trigger to the
To the
onset
event.
of the
Yeah.
event is so long, and there's so many multiple factors that can
Yeah,
come into it, so many
absolutely.
variables, that they're not going to point the finger. And no one can do a study because, well, who's going to fund it and who's going to actually do it? So it's all association. So you have to go back and look at huge numbers. And then in countries, this sort of can be done in countries in Europe where they have socialized medicine, like Sweden and Finland and England, where they keep tabs on everybody, especially the Scandinavian countries where everybody's in the system, and they keep records of every prescription ever made, and they know if it's filled, and then they look at all the diagnostic codes. So somebody would have to go through, and they do this for some things like ovarian cancer. They have looked at some things, but they haven't looked at dementia that I have ever seen, looking at how many years and at what age a young woman started birth control pills, and then what was her ultimate dementia type of event. But somebody needs to look at that, because I'll bet, and you'll bet the same, we'll both be betting on the same thing, is that yes, it does increase it. And we know that, for example, with osteoporosis, that even a little bit of extra estrogen in the early years of the reproductive life can have dramatic impacts on fracture risk later in life. So it doesn't take that much here, like a little thing, to create giant effects later. So I can't believe that it doesn't. And when I look at 90% of women in the United States are on hormonal contraception. And they think that if they're using the IUDs that they're home free, but those hormones are suppressing ovulation in at least 50%
At
of
least
women.
50%, at
Yeah. And
least.
so they're not having the proper hormones.
Mhm.
They're not having, and once you
Well, and
understand that
even if they were maybe
cycle,
not fully suppressing, I have to believe that they're still diminishing
yeah,
those
they are
hormones. I
diminishing.
mean,
Yeah,
even if women are ovulating some of the
that's
time,
right.
there's still a diminishment that's happening. I would say that that's not optimal ovulation either, you know?
No, and it is definitely altering how the hormones are being produced. If it's suppressing ovulation, it's huge
Oh,
effect.
yeah.
And if it's just diminishing the ovarian production of hormones over time, that is also a huge effect. That's the hormesis, a little something creating ultimately a big effect.
Yeah,
So
absolutely.
yeah, so for sure. And then look at the issue of mental illness. What's the data on that? It's I told you like almost a quarter of women are on antidepressants from age 40 into the 50s. And just as a general statement, it's close to 20% of people now have been told that they have mental illness or they know it. So and that's probably an underestimate because most people are not actually seeing healthcare professionals. They're
I
just,
mean, in
yeah.
terms of, I'm not going to get on anything like in pharmaceutical wise to manage my rage without the road, and I know it's a hormone imbalance. I know that I need to be supplementing. And, that's why I was really curious. My gut instinct has been is like, I need to look at estradiol, and I've looked at it on different areas of my continuum, but not across the entire board. I've looked at a snapshot here, I've looked at a snapshot here. When I was breastfeeding, it was just, it was depleted across the board. And so, now that this has been 3 months of this, I know that I need to dig deeper into, it probably isn't just, obviously it isn't just progesterone, because that's what I'm
No,
taking, right?
and this is where it's so important to understand that the trajectory of perimenopause. So the trajectory is down,
Yes.
but along the path down, you can have spikes up. That's
Yes.
like a roller coaster. So that's the one time when you can have true estrogen dominance that has to do with ovarian produced estradiol, only in the perimenopause. Otherwise, you don't have that. If you have so-called estrogen dominance, it's because you have too much estrone being produced by adipose tissue or endocrine disruptors. That's why I don't like that term, because no one knows what it means when people use it. So I just describe what it really is, what's really happening in the body. But during the perimenopause, there are times the estrogen levels going down, but then it can spike up to really high amounts. So and this is not proven, there's not published data, but if I give estradiol like a baseline, why do those gigantic spikes and then dips, why are those occurring? Because the brain, which has sensors to pretty much everything and it has to estradiol, the brain sees the levels going too low, so it shoots out the information to the pituitary gland, which then puts out this explosion of gonadotropins, LH, and then FSH. And that in turn creates this hyper response in the ovary, which is still capable of responding, not forever, but at that time, it's still capable. So the estrogen production shoots up, but then it goes down again.
Right.
So then it goes up again. That's why the perimenopausal years is the most common time for fraternal twins.
Yes, because those ovaries will pop out too. She's like, oh, I
Yeah,
didn't do it last month, but let me just
that's
get
right.
these two out this
Maybe they
month.
think they can't have kids and then they have twins
Yes.
because it's like a hyperstim.
Yeah.
So if I give estradiol, just like a baseline, then the brain will always know there's enough. So it won't do that shooting up of the
So
gonadotropin.
we won't have the
So I'm
big
calming.
swings.
And so instead of going down, I'm like giving a plateau. Now you may have a
Interesting.
little bit of spikes, but it's really helping. There's no published data on this, but I have
What?
a lot
I
of,
have never even considered this as a
yeah,
possibility. I'm just
it
mind
keeps
blown
things
right now.
like instead of
I
this,
just figured we just had to endure that. We
no
don't.
way. No, we can keep that from going like this with the big spikes
Oh,
going down. We can just level it off and make only maybe a little bit of spikes so that we can just take that whole trajectory and change it in a way that can keep people calm. Because what they found, for example, with bipolar 2, which is much more prevalent in females,
Yeah. Oh
it's
yeah.
not, it's, and just like migraines, by the way.
My,
Oh,
but yeah,
perimenopause.
so that's me. So I have 3-day migraines
Mhm. Yeah,
at the exact same time that I have this
okay.
perimenopausal rage. And so I am not only overstimulated and I have intense pain, but I'm also rageful and I'm a gentle, positive parent.
Yeah,
And
I
so
can tell. So
my
here's what they
husband gets
found.
it. Let me tell you, my son does not. But
Uh,
I feel like I'm like it's a lose lose. I have these horrible migraines, and I'm in this rage moment, and I'm just praying for an end.
so, well, we really do understand this now. The trigger to most, nothing is 100%, but most migraines, which remember 80% are in women, the trigger to most migraines, I mean, there are other triggers too, but when we're talking about the hormones, and also for exacerbation of bipolar, is fluctuating. It's the drops. And this is, remember, the trajectory down and spiking and down and spiking. So if we can keep things level and you don't have big dips and spikes, oh my gosh, you can tremendously ameliorate mood changes, mood problems, and migraines. So giving baseline estradiol, and by the way, there's published data on this with migraines, that you can prevent the migraine by giving that baseline estradiol, by just doing it either a cream, a gel, a patch. You can pick the one that works for you. And by the way, this another thing that happens around the perimenopause is appetite dysregulation, like cravings
Oh,
and
I know.
binging and
Oh,
night eating. So there's actually also this one, there is published data that giving estradiol can dramatically lower cravings and binge eating.
mm, that's
So
amazing. It's
I,
crazy, Dr. Gersh. I woke up with a migraine today. I am a little too. I would feel like, let's see, what day am I? I'm still in my first week of my luteal phase. I ovulated like 4 days ago.
oh,
And
well, you had that big drop. That
today
could
was my
trigger it
first
to be,
migraine. And I'm just like, yeah, oh, because
well,
I don't know. It's a crapshoot how many I'm gonna have between now and my first day of my menstrual cycle. And I
well,
woke up with
these
it.
fluctuations are, for some women, they totally trigger this
Yeah, I made sure I woke up early
inflammation.
enough. I wake up and I'm like, is it? And then I was like, I need to take something because I knew I had this big interview with you and I wanted to show up fully present. And so I was like, let me just knock this thing out with drugs real quick so I can show up today for you. And I let my husband know too, because I always need to let him know, just to let the family know where mama's at, you know.
There is a place for drugs. I'm integrative.
Like
I'm not alternative,
it's
but
yeah, it's
we
a pain,
don't, we
like
hate
Excedrin
the
migraine. Yeah.
rescue, right? Sometimes you need to do rescue. I mean,
Yeah.
but the reality is that our goal is prevention
Yeah.
always, not rescue. But we have, sometimes we have to do rescue too. But
Yeah.
anyway, I'm glad you seem to be totally on your
My
mark.
game this morning.
Yeah, yes, you are. Doing great.
I mean, I manage with them so much. It was once I had my son at 41, but it was my whole pregnancy. I probably had 50 migraines, give or take, and they've
Oh,
continued since. Um, so I've had them for now consistently for 3 years, and they've gotten worse since
whoa.
they've gotten worse this year, especially since I stopped breastfeeding. So yes,
Well, that's
yeah.
breaking my heart because that's really alters your quality of life. So
Mhm.
definitely, it's, and there are, I mentioned, like fluctuations of estradiol can be a huge trigger, but there are other triggers like not getting enough sleep,
Yeah.
or sometimes even like getting different light exposure, circadian rhythm disorder, inflammation, chronic viruses like COVID, so, and that can, anything that creates inflammation will create neuroinflammation. So
Yeah.
definitely your project. We got to get you right. But it could be as simple as just getting a little background estradiol going in you all the time to keep things from getting too fluctuating with your estradiol production. In the 40s, there's no question that things are changing. The average normal so-called menopause in the US is 45 to 55. Remember, this is defined as an entire year without any bleeding. So 45 to 55, if you're someone that's actually going to go through menopause in your 40s, then when you're in your first half of your 40s, you're already well into perimenopause if your last period is going to be at 45, 6, 7, or 8 even. So definitely, I can tell you that there's almost 100% that you are perimenopausal. So
Oh
there
no,
you go.
I'm
It
well
is
aware.
what it
Yeah.
is. Yeah. No,
Absolutely.
no, you are aware, but there may
Oh,
be
yes, many women who have
listeners
no
out there
idea.
who think, oh, I'm only 43 or I'm only 42. This can't be me. No, yes, it can be,
Mhm.
definitely. And there are just as many women who go into menopause in their late 40s as in their early 50s. The average is like 50, 51, but it's spread across 45 to 55. And then there are some women that are between 40 and 40 up to 45. That's called, and over 55 is late. And before 40 is called premature. And it is definitely an issue of early onset, like you mentioned before, like what's happening. Well, we live in a world that has so many endocrine disruptors, everything that creates disruption of your natural hormones. Inflammation can age the ovaries, damage the eggs, and limit your ovarian lifespan, which affects your health span. So the longer you have ovarian function, the longer you will have health span. And even when we give hormones, which I give very readily, it's not quite the same as having normal ovarian function. We do the best we can. So having normal ovarian function as long as possible is really important and very, very contributory to health span. So everyone should eat lots of vegetables and exercise and get sleep, avoidance of environmental chemicals and toxicities, and so on, because all of those are contributors to advanced aging of your ovaries, which is really not been appreciated. The ovaries, as a gynecologist, I always questioned, why are we taking out, this was standard. Now it isn't, but it was for decades, that if you did a hysterectomy for a benign disease like uterine fibroids,
I know.
there's nothing wrong with the ovaries. The ovaries are just sitting there minding their own business in someone who is, say, 43. They're 43, they have ovarian function, maybe they're in perimenopause, but they're not in menopause. They may have another decade left of ovarian function. And it's like, well, you're already there. She's over 40. She's not having any more kids. What difference does it make? They could cause cancer. You could get ovarian cancer. So if you're doing a hysterectomy, just take out the ovaries. We have done, and I always said, why would we take out the ovaries? Just because they're in the neighborhood? They're not doing anything. They're not part of the problem. It's like, oh yeah, it's preventative medicine, because then if you don't have ovaries, you won't get ovarian cancer. Ovarian cancer, which predominantly is actually fallopian tube cancer. Now we understand it. The vast majority of so-called ovarian cancer actually originated in the fallopian tube. But that said, for whatever number of women we prevented ovarian cancer, we did way more damage in terms of taking out those ovaries unnecessarily. So that's like the sad part of conventional medicine, when they mean well, but they do terrible things that harm people. We now know that just taking out the appendix, for example, for no good reason, just because you're in the neighborhood, also increases a lifetime risk of colon cancer. So like nothing is purposeless in the body, and the ovaries continue to make testosterone for life. And now they have published data that removal of the ovaries unnecessarily for no reason other than you're just in the neighborhood before the age of 65 shortens women's lives. That's how important ovarian health is, even without estrogen and progesterone, just the testosterone. So we never want to underestimate the value of ovarian testosterone production to health span as well. So don't let anyone take out your ovaries for no good reason, please.
Thanks for sharing that, because I know that there is very much a correlation between ovarian function and ovarian aging and just overall aging, and that really the intention is to have ovarian longevity, reproductive longevity for as long as possible, as long as we can, ride it till the wheels fall off.
And then, like you said, and we started, don't wait until end stage ovarian aging to start hormones. Don't wait to the end. Wait until you begin. Okay. You don't want to start hormones when you don't absolutely need them. You have perfectly functioning ovaries, but delaying the onset of hormone therapy is not a good thing. We know that you start losing bone, you start losing collagen. The quickest way to know if your estrogen is declining is look in the mirror, because the skin is the outward reflection of inside everything. And the skin, every layer of the skin has estrogen receptors, the epidermis, the dermis, the sebaceous glands, the sebum production, the hair follicles. There's not one structure in skin from top to bottom that doesn't have estrogen receptors. So without estrogen, you don't make the same amount of collagen or elastin, or you lose the fat, the proper support fat in the skin, the ceramides that keep in moisture, the hyaluronic acid, the hair follicles like wither, and then you get finer hair, and so on. Androgenic alopecia starts to become dominant. And everything about your hair and your skin is reflection of your estrogen status. So if you think, oh, my skin is really getting dry, oh, I'm really starting to show a lot of wrinkles, that is a really clear clue your estrogen levels are declining. And that doesn't mean, oh my gosh, I'm 25. There is a point we don't do that. But the reality is, because you remember, everything is aging from the day you're born. But really and truly, if you're like around age 40-ish, and you're really seeing some significant changes in your skin, then also your oral hygiene, like you go to the dentist and the dentist starts saying, oh my gosh, you're having so much gum recession. What's going on here? Another big red flag, your estrogen levels are declining, because the mouth is very, very key to estrogen status. When you don't have enough estrogen, you have changes in your oral microbiome, your gum health, and that's why women have very high rates, very sad, of tooth loss. So we don't want that. So that's another clue. If you start suddenly having changes in your gum health and you don't know why, because it's like nothing's changed, I'm not doing it. But yes, also another big clue is, belly fat. It's like, what is happening to me? My waist is going, I'm getting this belly fat, I'm eating the same, I'm exercising, because estrogen regulates
Insulin.
the creation of energy, insulin, adipose tissue functioning.
Yeah, fat distribution.
That exactly.
Yeah.
So
You want your fat to move over to your tummy, lose that estrogen and don't replace
that's it. Yeah. Also, if you find changes in your sleep quality, that you just kind of middle of the night awakening, you're not feeling rested, you just start peeing a lot during the night, that type of thing is another really high clue. Of course, night sweats and hot flashes is like the most obvious, and vaginal dryness and change in sex drive can be related to estrogen. Also, if you feel like you're sort of removed, like you don't feel like you're bonded to your family as much, because your oxytocin is
like a
related to your estrogen.
disassociation.
Yeah, like you feel like, like just leave me alone, everybody. I'll just sit here in the corner, and look at my cell phone. Like you don't even want to socialize so much. That's another clue. So you can, so you got to be your own best detective for your own health, because your doctor, meaning well, the same doctor that took out all those ovaries unnecessarily, they're different, which are often way behind the times in terms of what really is indicated and medically best. So you got to be your own best advocate, your own best detective of what is happening in my body that is really showing that my estrogen level is dropping. And of course, mood changes. Like suddenly you're having PMS where you didn't have it before, or road rage without the road or with the road, right?
Oh,
So, that type of thing. So these are huge clues that, yes, you really will benefit from some estradiol supplementation, not replacement, but supplementation. And we don't do that with thyroid. We don't say, oh, you're just a little hypothyroid, so we'll just ignore it. No, we want to treat to optimal, like you said. And in pregnancy or fertility issues, we are so strict now, right? This is the consensus. You got to get that TSH to be
yep.
between 1 and 2.5, no exceptions. No, you put them on some thyroid. Well, why are we not looking for optimal at every stage for every point
Yeah,
in
it
life?
was interesting that, obviously I have my thyroid taken care of by a good dear friend of mine, functional doctor. But when I was I was pregnant at 40, my OB-GYN, I'd never seen anyone in the conventional world care about my thyroid like my OB-GYN did during the time that I was pregnant. Like
I know.
I was really
Otherwise,
fascinated. I was
after.
like, oh, this is interesting. Like I'm already managing it over here, and we
Yeah.
were on top of it too, but she was extremely interested in making sure that it was in optimal range. And I was like, gosh, this is the only time I think I've ever had someone, in the conventional sense,
Well,
pay attention.
well, let's hope this will grow, right?
Yeah.
So that we don't just care about it when you're pregnant or trying to get pregnant. Why don't we care about every hormone in the body being optimized at every stage
Yeah.
of life?
Yeah.
And it sure would benefit every
Yeah.
woman with her health span. I've
I
had
also felt like the only time anyone was really it was really interesting to me during pregnancy was the concern around insulin. Like obviously insulin resistance is a natural response in pregnancy, but really paying attention to that gestational diabetes. And I was like, oh, wow, they really, I feel like so many women are pre-diabetic and no one's saying anything. But during
oh
pregnancy,
yeah.
especially at my age, they were like, we need to stay on top of this. And I was like, gosh, well, why? How about the other millions of women in their 40s who have insulin resistance or are on the like precipice of prediabetes, and we're not saying anything, but during your pregnancy, like we got to stay. It was just really fascinating to me how hyper aware the medical system was around those type of things.
And then
And then we didn't care once I wasn't pregnant anymore.
I was going to say exactly that. And after the baby's born, it's like, oh, whatever.
Good luck. The
I
last
know
question I
it
had.
is funny.
Last question I had, because this is just kind of blow my even just getting us off that estrogen roller coaster, which feels just so intense and havocy. In your personal experience in practice, what is the average age of women in perimenopause that you find that kind of you've been supplementing with estradiol? I was just curious from your own personal perspective. Is it 43? Is it 44? I mean, obviously it varies. And most women at 43, 44 are like, I'm not even in. A lot of women don't even think that they're in perimenopause at this age. And I'm like, oh no, you're in perimenopause. So I was just curious, Dr. Gersh, what has been your experience?
Well, in my experience, it's more in the mid 40s
Mid
and even
40s.
a little bit later 40s. That's only because they're the ones that are
Coming to you
yeah,
with the symptoms.
exactly.
Yeah. But like
Exactly.
those
For
symptoms
my,
have been intense for a minute and they're
you know,
finally coming to you.
because people don't know. They
Mm-hmm.
don't know.
Mm-hmm.
And many of them are going to doctors and they're being told either this is just what it is,
Yeah.
like
Oh,
not
absolutely.
complaining.
It's totally normal. This is just what it is. Your
It's just
labs are
normal.
normal. Yeah.
And yeah, you'll lab them, or some of them, like a quarter of them, are getting put on antidepressants,
Oh,
and,
absolutely.
and they don't know. They
Or
because
birth
they
control.
don't, if you don't know what you don't know, then why would you take any action?
Yeah.
So that, it's really, that's why I'm so happy you get to talk about this, that it does matter. Perimenopause is a real thing and real problems are happening and they're being treated or not treated in ways that are not optimal for the individual woman. So we got to change this whole, reframe the whole thing of menopause as a process of ovarian aging, not like you cross a finish line, and more a little bit along the lines of where the trend has been with insulin resistance.
Yeah.
Like the whole trend of insulin resistance is don't wait till you're full-blown diabetic. We want to get aggressive with insulin resistance long before you're a full-blown diabetic,
Well,
which of course,
especially for women. I mean, once we're full-blown diabetics, our risk factors for dementia and cardiovascular disease just skyrockets. Like we needed to flag women before prediabetes, particularly. And that's where my outrage begins.
there's even a little bit more trend, a little bit of even among rheumatologists, but just the beginning of looking at autoimmunity before you have the end stage autoimmune disease, like looking at antibodies like Hashimoto's antibodies, a positive ANA, looking for signs of an autoimmune process before you have end stage disease. We certainly do that with cardiovascular health. We look at high blood pressure long before someone has their stroke. And so why are we not thinking about being proactive with hormonal decline in the perimenopausal woman and looking at the trajectory of ovarian aging? We're doing that a little bit more and more in these other areas of health, and it now needs to become standard of care that perimenopause is the continuum on the trajectory to menopause, which has huge metabolic shift events in women. And metabolic health is the creation, utilization, distribution, storage of energy. And every organ of the body needs to have energy. That's the difference between something living and something dead, is the ability to create energy. And metabolic health is essential to optimal functioning and quality of life. And this is hugely—
It's our life force.
It is.
This is the drum I'm beating. It is perimenopause, not menopause, where we have to be optimizing our hormones and our metabolism. We cannot wait until we're 50. We cannot wait until 52 to have this on our radar. And everyone, like no one's flagging this late 30s, early 40s, mid 40s. And I'm like, by the time we're in our 50s, like the lipidemia, the fat distribution, the belly fat, all of the insulin resistance, it is there. It's alive and well, where we could have gotten a handle on it in 8-10 years ago, with the shifts and changes of our hormones. Because you said it's this natural decline. It's been happening. We're at ground zero. That it was during the transition that we needed to care. Obviously at any time it matters, but
like hitting the full-blown definition of menopause is like waiting to do anything and not taking any action until someone has their like really serious heart attack.
Yes, once you have the disease.
It's late in the game. That's like such a key message. By the time your periods have been gone for a year, you're already late in the game of ovarian aging, and a lot of damage and changes have already occurred in the body. And truly, we can always do better wherever we are on the timeline, but we can't undo the pain.
We can't undo what has happened. Right.
No, we can't. We can't do like, let's do a redo. No, we do not. We have to then do the best we can from that point forward, but we can't rebuild all the things that are broken down. And we need to get proactive. So that's why I appreciate so much that we could get together to deliver this message that is so critical. There's so many women that are at this point and they don't know why they feel different emotionally. They're looking different. Their GI function is different. Their sleep is, they see changes and no one is helping them. No one is even acknowledging what is happening in their bodies. And so it's so important. I always say over and over, the first step in solving a problem is to identify and define the problem. And that's what we're doing. And then the next step is solving it.
Thank you so much for coming on. This has been such a profound conversation. I feel like you have validated so much of what women are going through. I believe that there's 50 million women in perimenopause in the States alone right now and I feel like women didn't even know perimenopause was a process a decade ago and still don't know right now, right. But it wasn't even on our radar. I just women just suffering and no one having anything for them. Like, that maybe they were crazy, we're like, well, you're not in menopause yet. So Don't worry about it. And so I just really appreciate this really powerful conversation. And I'm walking away with so much. And I know I'm seeing the signs. And there are areas that I have filled in the gaps, but there are still gaps that I'm trying to fill in at 44. Like I am in the tunnel. And I just really appreciate this conversation today, because I know that what I'm going to do in terms of pivoting in my own care literally in the next month or so is going to profoundly impact my health span moving forward. So thank you.
Well, you are so welcome. And everyone out there, take a survey of yourself, your health, your habits, and then take action, because this really matters. And there really are so many things we can do to live healthier health spans.
Oh, and Dr. Gersh, where would you like us to find you? What would you want to point us to?
Well, I'm a practicing doctor. I
Yes.
have a regular office in Irvine, California, that's Southern California, called the Integrative Medical Group of Irvine, where I see patients every day. I also have an Instagram, which I try to stay reasonably active on. That's Dr. Felice Gersh. I have 3 books out, and hopefully we'll have more. I have 2 on polycystic ovary syndrome, PCOS SOS, and PCOS SOS fertility fast track to help women get pregnant really rapidly and successfully. And my most recent book is Menopause, 50 Things You Need to Know. And it goes through the 3 stages of menopause. And of course, the first stage is perimenopause. So I have a whole big chapter on that one.
Perfect. I will link to the books. I will link to Instagram, and yes, I knew you were in Southern California. I'll have those details as well to your website, so people can come and find you if indeed they're looking for that level of standard of care that you so beautifully deliver. Thank you.
My pleasure.